if in India we could put on the next presentation, which I think is also a video sent by Dr. Frank Veith from New York. And his presentation is really having a critical appraisal of the randomized controlled trials for EVAR versus open surgery in the treatment of aneurysm. So in India, please can we put his presentation on when you can?
It's a real honor to speak on the evolution of EVAR for the treatment of ruptured AAAs, from oddity to standard of care, despite 3 randomized trials showing otherwise. And I would like to thank Professor Khanna and Dr. Michel Henry for inviting me to be part of your meeting this year. I have no conflicts, but like everyone else, I have lots of biases. The use of endovascular tools and grafts in the management of ruptured AAAs is a concept we have had since we did our first EVAR back in 1992. The reason to pursue EVAR for ruptured AAAs is the high mortality and morbidity from standard open surgical repair, so there's clearly room for improvement. In addition, EVAR is intuitively better because it minimizes dissection and decreases blood loss, hypothermia, vessel injury, and coagulopathy. It's so obvious, one wonders why endografts were not used sooner to treat ruptured AAAs. Well, it was simple in the beginning. It took time to procure endografts in emergent situations. We had the solution, our own surgeon-made MEGS endograph, which could be prepared and kept sterile in our operating room to treat emergent situations. This was our own surgeon-made MEGS graft made from a tube of PTFE and a large Palmes stent, and this could be placed just below the renal arteries and brought out through the femoral artery. So combined with a fem-fem and contralateral iliac occlusion, it could be used to treat most, even complicated AAAs. This graft was also a one-size-fits-most, because by varying the inflation pressure in the balloon, one could treat different diameter aortic necks, and by cutting off the excess graft and doing an endovascular anastomosis, as shown here, within the artery, one could treat different lengths of aortic pathology. Because this MEGS graft could be sterilized ahead of time and kept in the operating room for urgent cases, we were able to do the first EVAR for a ruptured AAA anywhere in the world. In April of 1994, the patient was inoperable because of a very hostile abdomen and a very bad heart. He was in shock and with severe pain. His angiogram showed clear evidence of free rupture, and we were able to treat him with our surgeon-made MEGS graft. His aneurysm was successfully excluded by our MEGS graft, and the patient survived for more than 3 years, only to die of his comorbidities. Encouraged by this experience, in 1994 and 1995, we treated another 11 patients, all of whom were a prohibitive risk for open repair. Surprisingly for us, in these very sick patients, there were only 2 deaths, giving us a remarkable, for us, only 17% operative mortality. These favorable early results in impossibly high-risk inoperable patients led us to the hypothesis in 1995 that endografts and other image-guided endo techniques should be employed to treat all ruptured AAAs, even in good risk patients. From 1994 to 2000, almost no one else in the world agreed with us. They all felt that open repair was the best treatment for all ruptured aneurysms. Our results over the years, with 57 patients having ruptured AAAs, we were able to treat 45 with endografts, and in these 57 patients, we had a remarkably low, only 12% mortality. So by 2000 to 2005, our and some other rare centers' results suggested that EVAR improved treatment outcomes for ruptured AAAs. However, some groups have had poor results with EVAR for ruptured AAAs. Notably, 4 controlled studies showing EVAR to have no better results than open repair. The last of these studies was published from Sweden in 2015. So it's fair to say that as of 2009, EVAR for ruptured AAAs remained controversial, and there were many who said that we need a randomized controlled trial comparing EVAR to open repair in this setting. We believe the treatment strategies, adjuncts, and techniques outlined in our 2009 Annals of Surgery article do make a difference and may account for the better results which some groups could achieve. I don't have time to go into all the elements, but they are mentioned in that 2009 Annals of Surgery article. Some really important ones are shown in the next few slides. A key one is to sharply restrict resuscitation. We call it hypotensive hemostasis. If the patient is moving and talking, it's okay, and one need not worry about a low blood pressure. It's important to place a transfemoral wire in the supraceliac aorta under local anesthesia. We only place the large sheath for the balloon and inflate the balloon if it's absolutely necessary, that is, if the patient crashes, and that is only so in about 25% of cases. Hypotensive hemostasis works in about 75% of cases and allows deployment of an endograft. When it doesn't work, supraceliac balloon is needed. The technique for placement of this balloon is key. It's not simple. Check it out in an article by Berland et al. In the JVS in 2013. Here briefly is how to do it. A large French sheath is placed via the left femoral artery, and through it the supraceliac balloon is guided by fluoroscopy and inflated into the supraceliac aorta. The sheath must be left in place to support the balloon and to get it out. Then the body and ipsilateral limb of the endograft is deployed via the right femoral artery. A second balloon is placed via the right side in the body of the graft and inflated, and then the first balloon is removed via the sheath which has been left in place. Here shown is the balloon supported by its sheath via the left femoral artery, while the main endograft is being deployed via the right femoral artery access. Injection via the sheath shows the renals, which allows precise endograft deployment. For further details, check out this JVS article by Berland et al. Another top tip is to watch for and treat the abdominal compartment syndrome. I don't have time to go into all the details, but they're mentioned in this article by Lachot from the JVS in July of 2009. And here's an example of such a case optimally treated. Despite all these points and our firm belief that EVAR is the best treatment for ruptured triple, this has remained controversial up until at least 2016, and many still are saying that we need randomized trials comparing EVAR to open repair. And three of such trials have now been completed. They are the ICAR French trial, the AJAX or Dutch trial, and the larger, more important, improved trial from the UK. All three trials claim no difference in 30-day mortality between EVAR and open repair. However, that conclusion is, in my opinion, flawed, misleading, and just plain wrong. And here is why. The ICAR and AJAX trials both excluded high-risk patients in shock and too sick for open repair, and those are precisely the patients most likely to benefit from EVAR. Here is an example. As you will see, this patient could not have had an open repair, but was saved by an EVAR. she would have been excluded from all three randomized trials, as you'll see. She was an elderly Jehovah's Witness with severe abdominal pain, a blood pressure of 80, and clear evidence of aneurysm rupture. She had a hostile neck and refused blood transfusion, so I spent the better part of an hour trying to talk her into accepting a blood transfusion, and during that time her hematocrit decreased to 17%, her blood pressure fell to 60, and she stopped talking. You can see here the bad neck. Our anesthesiologist refused to put her to sleep because she refused the blood transfusion, and we felt we had no other choice but to try to treat her endovascularly despite her bad neck. At the time, we only had an Anurex device available, and we used that, and with some difficulty we managed to treat her and exclude her ruptured aneurysm, as you can see here. Remarkably, we were successful, and the patient remained well for more than 7 years. How about the larger and better UK IMPROVE trial? The IMPROVE trial was a large, multi-center, randomized trial, carefully done, and its early and late results have been published. Its main conclusion at 30 days and 1 year was that a strategy of endovascular repair was not associated with significant reduction in 30-day or 1-year mortality. This conclusion was widely quoted on the internet and in Vascular News as showing no difference between endovascular and open repair. Here's why this conclusion is misleading and just plain wrong. Even though there was no 30-day mortality significant difference between the EVAR strategy group and the open repair group, one has to see the details to appreciate the flaws in IMPROVE. Time does not permit me to go into the many flaws in IMPROVE, but one key flaw is that of the 316 patients randomized to an endovascular strategy, only 154 actually were treated by EVAR. That's less than half, and their mortality was a low 27%, while in the same group, those patients getting an open repair actually had a higher mortality of 38%. So to me, it seems that the IMPROVE trial clearly shows that EVAR is the better treatment for ruptured AAA patients if it can be done. In addition, the most recent results from IMPROVE confirm EVAR superiority with better long-term survival overall with EVAR and better short and long-term survival in women. So my conclusion today is that with EVAR for ruptured AAAs, the low mortality around 20% and the many inoperable cases that can be treated successfully with EVAR show that EVAR is a better way to treat ruptured AAAs in anatomically suited patients. Moreover, if the skills and equipment are available and the anatomy is suitable, EVAR should be the treatment of choice for ruptured AAAs in 2021 and beyond. A second conclusion: randomized trials, so-called level 1 evidence, are not always the infallible holy grail they are thought to be. And finally, as with everything else in this world, how you do EVAR for ruptured AAAs matters, including some of the strategies and technical tips I've shown you today. Professor Khanna and Dr. Henry, thank you most warmly for your invitation, and thank all of you for listening.
Fantastic. So we should thank Dr. Veith for a very, very clear message on how he feels regarding the 3 initial trials to treat ruptured aneurysm. And I think most people who've been doing endovascular surgery for some time completely agree with his thoughts and comments.